earlier you were talking about family planning.
Yes.
And so my friend over here is Akshay. So he's also married. So it's really great to have you, Akshay, over here.
Yeah, I had one question, ma'am. Ma'am, it was like you told like just inform about the vaccine. So like how many people are aware about the vaccine? Like
how many do you think out of the three of you, how many were aware of the vaccine?
I think only me. Yeah.
Even my wife also does not know about that.
Right. So that is the main problem here, is that we are not aware about the vaccine. Some of who keep going to the pediatricians around the age of 9 to 15 years will be told about this vaccine by the pediatrician. But that is another reason why a regular visit, just a formal one to a gynecologist is essential. The cervical cancer vaccine has been around for the last 15 years or more in India, but not many people are aware of it. So those who've lived abroad or who've spent some time abroad and come back, they tend to have better idea. Many of them have come and approached me to take the vaccine. Is it really available in India or no? And second is when we as gynecologists keep having a constant process that we obviously talk to our patients. So we ask them how many children they have, whether boy or girl, and we do advise them that have you given the cervical cancer vaccine to your daughter? So the awareness of this cervical cancer vaccine is very less, and time and again we've been trying to create awareness about it. It's a very simple vaccine. It's just like a shot, like you would take a flu shot or any, a BC, and its exact schedule is like a hepatitis B vaccine. So while a hepatitis B vaccine is also given at 0, 2, and 6 months interval, a cervical cancer vaccine is also given at 0, 2, and 6 months interval. And if you're younger, like I told Mayur, that if you're between 9 to 15 years of age, that's the ideal time to give the vaccine, because you require only 2 shots. So you save on that one shot and the one prick in between, and plus you save on money also, because it's not a very cheap vaccine. It's quite a reasonably priced vaccine. And there are 3 forms of cervical vaccine. One is a bivalent vaccine. Then there is a quadrivalent vaccine. I don't want to give any brand names or company names. And then there is a 9-strain vaccine, which has just recently come into India. It was supposed to come about 2 years back. Unfortunately, because of the COVID pandemic, the launch into India has been delayed. But it is effective against 9 strains of the human papilloma virus vaccine. So that's the current one, but it is currently priced at the price of 9,000 per dose. But the more commonly used one, and which we've been using for the last 10 years, is the quadrivalent vaccine, which is quite effective because it does protect against 2 major strains of HPV virus, which are known to be associated with cervical cancer. And that is the quadrivalent vaccine, or the HPV-4. Okay. It is commonly available in India by the name of Gardasil, by the company name of Gardasil. So even if you've got married and your wife has not taken the vaccine, but you've been recently married and she has been in a monogamous relationship with you, then she is still eligible to take the cervical cancer vaccine. The reason being is that even though she is exposed to some strains of the human papilloma virus as a part of intercourse, it may not necessarily be that she is exposed to the persistent HPV virus. So she may have just had a transient HPV exposure which goes away, but taking the vaccine will prevent her from getting persistent HPV infection. Persistent meaning prolonged. So it will prevent her from getting prolonged infection, and the vaccine will still be, even though she's been exposed to one strain, the vaccine will still protect her from the other 3 strains of the virus. So it's like, let me put it this way. People who got COVID infection are still advised to take the COVID vaccine. Correct?
Yes.
Yes, ma'am.
Why do we do that? Because we've got COVID infection, we've got certain antibodies, but we are not protected from the other variants of corona that have been coming and we've been seeing over time, Delta and Omicron and others. So that's the reason why, in spite of getting COVID infection also, people are advised that 3 months later, you please go ahead and take the COVID vaccine. Because if you later on, after 6 months or 1 year, get exposed to a different strain of coronavirus, the vaccine will still protect you and cause only mild illness rather than causing severe disease. So the same thing an HPV vaccine will also do.
Okay, ma'am.
Is it easier to understand?
Yes, ma'am. So like I had another doubt, like after taking like COVID shots, some people again suffer from COVID. So does the situation same in this vaccine?
Yes. Yes, so cervical cancer vaccine is only a vaccine. It is only a preventive measure. It will not completely eliminate the risk of cervical cancer, meaning that if you've taken the vaccine, it is not necessary that you will not get cancer at all. And that is another reason why, even though cervical cancer vaccine is being promoted, I still said that once in 3 to 5 years after marriage also and after being sexually active, a woman should go to a gynec for a pap smear screening test, which is a cervical cancer screening test. So the pap smear test has to be done irrespective whether a girl or a woman is vaccinated or she's not vaccinated from cervical cancer. Because the pap smear will be the first test to detect whether any abnormal changes in the cervix have started happening before the stage that it reaches cancer.
And next, LeAnne has some questions over family planning, so she would like to elaborate on that. LeAnne, you can take over.
Yes.
Yeah, so we were just talking about cervical cancer, and it's essentially a sexually transmitted sort of cancer, right? So, yeah, I guess we know, like, apart from this, there are a lot of STDs and a lot of other sexually transmitted diseases out there. So, taking that into account, what, in your opinion, are the most effective forms of birth control in that case? Not just to prevent birth, but also these other things that we need to be aware about.
Right. So basically, the birth control medications don't prevent sexually transmitted diseases. The birth control medications or the birth control pills or the I-pill, which is the emergency contraceptive pill, or even a intrauterine device, which is like a copper T or a Mirena device, they only and only prevent ovulation and prevent birth control. Also, they basically assist birth control by preventing a pregnancy from happening. But none of these modalities prevent sexually transmitted diseases. So for preventing sexually transmitted diseases, you need to have a physical barrier. So there are meaning of physical barrier. So in case of male partners, it amounts to condoms. So using condoms is a definite barrier to prevent STDs. The females are also not completely powerless. So they also have barriers available, for example, which is called as a vaginal diaphragm. So vaginal diaphragm is something which is similar to a condom, but the female version of it, and it is conformed, or its shape is to accommodate the female genital system. Okay, so vaginal diaphragms are available. There are something known as cervical cups, which are also available, which is again a female mode of barrier. Okay. Other than that, there are spermicidal jellies. So there are spermicidal jellies which not only prevent the sperm transmission and act as a prevention for pregnancy, but they will also prevent you from and help you get not get sexually transmitted infections. So these are some of the devices that you can use on a physical method to prevent sexually transmitted diseases. Other than that, the simplest way of preventing STDs is obviously know your partner well before you indulge in intercourse. And since you don't know if you're certain, it's always better to use barrier contraception, especially till the time that you're completely confident of your partner.
Okay, so yeah, a little bit towards that line, like extending it a little further. So you spoke about initially oral contraceptives and eye pills and stuff like that. So that, yeah, like you said, that's mainly used to just prevent the ovulation and prevent the pregnancy part. So what are actually some of the symptoms or the other side effects that women would get from taking these kind of pills? Because I know a lot of females who have taken like hormonal therapy, even for PCOD and PCOS, they've experienced a lot of other symptoms by taking it.
Right.
So like, what are the common things that usually come up?
Right. See, there is a difference between side effects and adverse effects. So adverse effects are like, those are effects which are not desirable and which could be probably harmful. And side effects are only effects which are not desirable, but they're not exactly harmful to the body. Okay, so let me just specify. For example, if I take a multivitamin capsule, I could, not tolerate a pill, but I could tolerate a tablet better. So I get gastritis or, I get hyperacidity because of taking pills. So which can happen even with a B complex vitamin capsule, and I get yellowish color in the urine, which is not very pleasing. I get a little kind of a, medicated smell in my urine, which is again not, but it is a side effect of the B complex vitamin. Right. But on the other hand, when I talk about adverse effect, I mean getting an allergic reaction to the B complex vitamin, or getting, rashes all over my body, having difficulty breathing. So these are adverse effects. So you understand, so even in cases of birth control pills, there are something like side effects and there are something like adverse effects. So any medication that we take over a period of time, and like birth control pills, unlike an eye pill, has to be taken persistently and regularly over every day, over a period of 21 days or 24 days, depending upon the composition of the birth control pill that you're taking. And since your body is taking a new tablet in every day, you're going to have slight side effects like gastritis, acidity issues, a little bit of change in taste of your mouth, a little change in your stool pattern sometimes, also a little change in your vaginal physiology. So some girls taking birth control pills for a longer period of time may experience excessive dryness in the vagina, change in their menstrual pattern, getting very little flow during their menses, change in the color of their menstrual flow as well. So these are side effects. They're not exactly harmful. Okay, but there are side effects which we have to bear with the tablet, because any medication that you're taking externally is going to have a side effect. But what I mean by adverse effects, now when I come to adverse effects, birth control pills can have adverse effects of causing I can say gallbladder stones, so there is a predisposition of increased incidence of gallbladder stones. Second is they could increase the incidence of increased deep vein thrombosis, which is clotting of blood in the legs or in the lower extremity vessels. It could cause pulmonary embolism, which is the clot from the lung, from the legs or from the lower limbs migrates to the heart and the lungs and causes blockage. So that is a condition which is quite serious, which is called as pulmonary embolism. It does increase the risk of clots going even to the brain, which is called as a coronary vascular accident, cerebrovascular accident, or a stroke. So these are adverse effects of birth control pills. Other common adverse effects is they can trigger a migraine episode. So somebody who is already a patient of migraine should not be taking combined birth control pills, because they can have increased incidences of triggering of migraine. So these are some of the adverse effects, and these should be made aware to every woman before she starts taking birth control pill. She should be explained that these are the risk factors, and their incidences are not as high as I'm talking right now. The incidence could be 1 in 1,000 or 1 in 10,000. So incidence wise, they should be made aware. And they should also be told that if you are developing any of these symptoms, for example, if you start feeling breathless, if you're starting feeling that your thighs or legs are becoming hard as a log of wood, okay, or if you've started having some kind of severe dizziness or severe headache, intense headache, stop the birth control pill or consult your gynecologist at the earliest. Okay, so there are side effects, but the side effects are, you can say that they are the cons, and we have to weigh the pros versus the cons. So for example, in PCOD, if the PCOD is to such an extent where the hormonal biochemical markers have changed and the woman requires to be taking cyclical hormonal medications for correcting PCOD, like I said, it is only 30 to 40% of the part of treatment. And so the gynecologist will also try to give medications to the minimal so that they come out of PCOD through the other lifestyle changes. And these medications are only given for sufficiently required period of time and not over lifelong period of time.
Yeah. So actually, then further related to that, you said earlier about birth control that you have to take it every day. So I did read somewhere that if you skip a dose, it does really drastically reduce the effectiveness of the birth control. So the thing is you have to be really consistent for it to actually be effective and not like even skip one dose, right?
Okay, not necessary. It depends upon the type of birth control that you take. For example, most of the birth control pills, so you have to read the content of the birth control pills. There's something known as progesterone only pills, and there's something known as OC pills, that is estrogen combined progesterone pills. So the birth control pills which contain both estrogen and progesterone, their efficacies are much better. The chances of failure on missing a single tablet are much lesser, and there are ways to correct it. For example, every time I give a birth control pill to a woman, I always advise that if you miss one pill and you remember it the next day, second day you take 2 pills. If you miss 2 days in between, the third day you still can take 3 pills and cover it up. It's not that you will have a failure of contraception. So if you miss one pill, next day as soon as you remember, you take one more pill, so that on the second day you are taking effectively 2 pills, one at the normal time and the usual time, and one at the time when you remembered that you forgot your last pill. If you miss 2 days, third day you will take 3 pills. But if you miss more than 3 days, you stop the cycle. Once you stop the cycle, within 10 days, the girl would get her menses earlier. Okay. So once she gets her menses earlier, she should restart a new packet of birth control pill from the third or the fifth day of her menstrual cycle, so that she's not blindly following the pattern that I have missed 3 days and now I'm just taking medications and to complete the cycle, because then she may have a failure in between. So the idea is, if you've missed pills, stop the cycle, let your menstrual cycle come earlier, and then start a new packet after the third day of your new menstrual cycle. Whereas there is a leverage of this 1 day, 2 day when you take a combined birth control pill. If somebody is taking only a progesterone only pill, because progesterone is a hormone which is a little volatile, it has a slightly lesser half-life, meaning that the tablet has to be taken at a more time sensitive period. So if I'm taking a tablet at 9 o'clock today, tomorrow, and I should be taking the tablet either between 7 to 11. I cannot default more than that. Because if I default more than that 7 to 11 p.m., that is 2 hours before or 2 hours later, then there is a chance that there will be a failure of my contraception. So the failure or the efficacy of missing a tablet would depend upon the composition of the birth control that girl is using. Most effective are the combined birth control pills. Certain conditions such as lactating women or women who are at a very high risk of stroke, or who are already have migraine episodes in the past or history of migraines, can't be given these combined birth control pills. So they have to be put on progesterone only pills. So that is why they have to be told that you have to be very time conscious. Okay.
Okay. That clarifies.
Yeah.
Yeah, so actually there was another question that we got from our survey related to this. So someone had asked related to eye pills, repeatedly taking eye pills, is that going to cause some kind of issues, or is that really not a good thing?
Absolutely, absolutely. Repeatedly taking eye pills is not the solution. Like, eye pill is been labeled for emergency contraception. So it is meant for the word emergency contraceptive. So somebody who's been taking eye pill repeatedly doesn't mean that she's facing emergency every time. She's just being careless. Okay, that means, see, if you are going to require an eye pill very frequently, that means that you require a combined birth control pill or a birth control pill which you can sustain, because you're going to have multiple acts of intercourse, period. So if you are going to require an emergency contraceptive, it has to be once in a blue moon only. It can't be repeated. So if you're a person who's noticed that I've been taking eye pill 3 times this month, then eye pill is not meant for you. What you require is a contraceptive pill which you take the whole month. On the other hand, if there are couples who are going to meet once in 6 months or meet once in a year, and they've had an accidental intercourse, and for some unfortunate reason they did not have a barrier contraceptive with them, then taking an eye pill, because everything happened in the heat of the moment, it makes sense, because you want to avoid an unwanted pregnancy. But that has to be that once in a blue moon time. Eye pill is basically a progesterone hormone, but a much higher dose of it. So it's a very high dose of a progesterone tablet, which normally is 15 times, I can say it is about 10 times the composition which will be in a single birth control pill. So you're basically taking that strength of a pill in one dose, a single shot, right? So that's why it suddenly prevents ovulation by causing the progesterone surge. Like I explained, the LH surge and the progesterone surge. So you're basically causing a surge in the hormone level by taking that eye pill. But the problem here happens is that eye pill is not 100% effective. By that I mean is that it will not definitely 100% prevent a pregnancy. It will only reduce the incidence or the possibility of you getting pregnant. But if you do get pregnant and you have not avoided the pregnancy, progesterone sudden high surge is going to damage your tube motility, the fallopian tubal motility. So the egg, instead of reaching the uterus, may get implanted in the tube itself. And these women end up with a pregnancy in an abnormal location, such as a tubal pregnancy or an ovarian pregnancy, which is otherwise called as an ectopic pregnancy. And they are dangerous to life, meaning they are life threatening also, because pregnancies in the fallopian tube or the ovary can't grow beyond a certain stage. After 2 or 3 months, they will finally burst out. Okay, so that's the reason why IPL is not a great idea. It is a good mode only as an emergency contraceptive. It has to be used very responsibly. Yes, it has to be taken within 72 hours. And if you've taken within 72 hours, there is a possibility that you could succeed, you may not succeed. You may get your periods delayed by 15 days. You may get them earlier also. Other side effect of taking IPL at regular intervals is that you're disturbing your menstrual cycle. So you're suddenly giving a progesterone surge in between where FSH, estrogen, progesterone, and LH, all these hormones have a particular timing, and you're suddenly putting high dose of progesterone in between. So you're going to start having menstrual pattern disturbances. So the cycles following an IPL could be very irregular. You could get prone to developing PCOD when you actually didn't have PCOD. Right?
Okay, so I wasn't really aware that it could actually affect you developing PCOD or PCOS, the possibility of that. So that's a new. Yeah.
Yes, because it's going to affect your menstrual cycle, no? Your normal cycle, which was otherwise ongoing. You suddenly put in a burst of hormone in between.
Yeah.
And make you prone to PCOD. So I'm not saying that a single IPL will, but eventually, if you're taking it multiple times, you're disturbing the internal menstrual cycle. So you're either going to develop PCOD or some other hormonal issue.
Okay, that's actually really insightful. Yeah, so I think like even in my own personal research, and I was looking up things and trying to find out, like what are the current birth control measures and stuff. A lot of it is female oriented, like birth control, eye pills, and apart from condoms, I don't think there's anything else that's really geared towards males. So is there any new innovations in male birth control per se that is like related to them in terms of like hormones or anything basically?
Unfortunately, the problem here is because reproduction happens in the woman, and the menstrual cycle and the egg growth, everything happens in the woman. So therefore, most of the contraceptives are mainly centered to the woman. If you have to go in for, because males do not have a cycle, so they do not have like a particular cycle, or there's not a particular timing which is a fertile period for them or an infertile period for them. But yes, what does happen is that so that is the reason why most of the birth control measures are directed towards the female, because they have an internal system which can be regulated or which can be modified. Their ovulation can be stopped, and that's why they are given these medications. In cases of males, the only thing that is possible is to physically cause a barrier from the sperms from getting ejaculated. So other than, if you don't want to use condoms, so you have to physically interrupt the coitus, which is called as coitus interruptus, or which is in other terms cause an external ejaculation. So that is another mode of contraception that can be used. And then there is obviously a permanent mode of contraception, which is called as vasectomy, where the vas difference is disconnected from the penis, and that is the reason why the sperms, even with a permanent contraceptive method like a vasectomy, these still have to use contraception for the next 3 months, because already produced sperms can still reach the female vagina. So that is why most of the hormonal medications and the newer techniques, whatever have developed, or there are a lot of developments that have happened in contraception, but most of them are all directed towards the female ovulation system, because there are multiple stages at which you could, prevent pregnancy. For example, in females, if you use a vaginal diaphragm or a cervical cup, you act as a physical barrier. Then if you insert a Copper-T or a Mirena intrauterine system, you act as a foreign body inside the uterus to prevent implantation from occurring. Then at the tubal level, if you disconnect the tubes by causing a family planning surgery like a tubal ligation, then you're disconnecting the tube. So you're preventing the egg from reaching the uterus. And then if you take birth control pills, or you use the IPL, you're basically preventing ovulation. So you're basically preventing the egg from getting ruptured at all. So there are multiple stages where in a female you could prevent fertilization from happening, but in the male, unfortunately, those stages are not there where you could interrupt. That's the main problem.
Okay. Yeah, that's unfortunate to hear. Yeah, but yeah, so you spoke just now about a vasectomy as an option, or even in the females, restricted tubes. Yeah. So it's further related to that. In that case, which surgery is more risky, would you say? Like, say you're in a marital relationship, you decided, okay, you're done having kids, you're like over now, and you permanently want a permanent solution. So which would you suggest, the female getting the surgery or the male? Which is more riskier?
See, if you ask me in terms of risk, then a female surgery is riskier, because for doing a female surgery, you actually have to get into the abdomen, get into the abdomen of the woman to actually do the surgery, because the tubes are within the abdomen and inside the pelvis. And either it can be done laparoscopically or it can be done through open surgery. But what we have to remember here, that suppose the couple has finished their family planning, so they've had childbearing, the woman has already undergone childbearing, which is obviously there has been some kind of a handling of the uterus. Majority of the times, nearly 40% women undergo C-section, so they've already had a surgery on them. Okay, so it's not like it's a bare abdomen or a virgin abdomen where no surgeries have happened most of the times. They sometimes have underhand miscarriages, so that's why they have undergone a dilatation and curettage procedure for cleaning the uterus, if they've ended up with a miscarriage. So a woman has already undergone procedures, and now if she has to undergo a family planning surgery, she again has to undergo an intra-abdominal surgery, because the tubes are not hanging outside. So even whether you do it laparoscopically or you do open surgery, there has to be a penetration and entry into the abdomen. Unlike that in males, the scrotum is outside the abdomen. So the scrotum is lower outside, and it is the vas difference are also just under the scrotal skin. So as a result of which, there is no intra-abdominal procedure that the male needs to undergo. Whatever is done externally. You understand? Because the male organs are external. So it's a much less risky procedure. It can be done under local anesthesia. That means that the male partner doesn't have to undergo full anesthesia. He can get discharged the same day from the hospital. Okay, and there is no side effect majorly. Like majority of men are not undergoing vasectomy because of the false impression in their mind that they'll become impotent if they undergo vasectomy, which is not the case. They do not become impotent. It's just that whenever they do have ejaculation, sperms are not released. They do have a seminal fluid as well, so the ejaculatory fluid also comes out, but they don't contain sperms. That's the only difference. So it's a much easier procedure to undergo in males rather than putting a woman through the ordeal of a family planning surgery. That it's not effective immediately, because even if the vas have been disconnected, the sperms are going to remain in the channel from the vas to the penis for 3 months. After 3 months, a repeat semen analysis is done. So their semen test is done. And once that semen test shows a 0 sperm count, that's it. Then they can stop using any other form of contraception.
Okay, yeah. I think that really answers the question. And I think I prefer this answer much more than the previous one. It's nice to know that
I hope
something
I've
is
not been as complicated as I was.
No. I'm just glad to hear that for once, like they're the ones who prefer to do something besides the females in terms of contraception. It's
So,
like it's always like geared a little bit towards to the
right.
females.
So
That is their
I
responsibility.
say that we would reach a more balanced society if both the couples take responsibility. The mother or the woman takes the responsibility of childbearing, and the male partner can take the responsibility of contraception. Then we would have a much better society.
Yeah, exactly.
Yeah.
So I think like we've spoken now a lot about preventing pregnancy and planning pregnancy. So let's flip it and talk about a little bit more people who actually want to actually get pregnant. So what would actually be the ideal age for females to reproduce?
I wouldn't say there is any ideal age to get pregnant, because the female, you could only get pregnant while between your menarche and your menopause, right? So that's the only range that ideally you can get pregnant. Within that range, if you want a suitable range, then the ideal time, would be once you are 20 plus or 23 plus. That depends upon, of course, socioeconomic and cultural backings, because certain cultural backgrounds say that you should have an early marriage. Some cultural backgrounds say that no, you get matured, get independent, and then settle and then have a pregnancy. But what we are talking about here is about health. So a 50-year-old can be as healthy as much even more healthier than a 35-year-old, so it depends upon how healthy you've been. So for somebody who's had a very controlled lifestyle, having very good physical health, maintaining good diet and good nutrition, could be healthy to get into pregnancy even at the age of 36, 37. At the same time, a girl who's got endometriosis, who's got multiple problems, who's had PCOD, would be suitable to undergo pregnancy at a much younger age of say 29 or 28, and not delay pregnancy to as much as 38, 39. So ideal range, if you ask me, earlier there used to be a very narrow range, 25 to 35. That is the ideal range to get married and to get pregnant and to have children. Now majority women and couples are getting married beyond 30, 31, 32, and even more than that beyond the age of 35. So the ideal age is till the time that the egg reserve remains good. Even though we have advanced our health conditions and we've been very fit, but still natural biological clock keeps ticking. The age of menopause is still the average of 45 to 55. So you have to plan your pregnancy before the age of 45 for sure. Number one, because your egg reserve will go down and then you would have to go in for only artificial reproduction. Okay. But if you plan your pregnancy before the age of 40, then ideally the risk of having chromosomal abnormalities in the unborn child, having Down syndrome or mentally abnormal or a mentally retarded child will be much lesser. Above the age of 35, the risk is 1 in 250, but above the age of 40, that risk is 1 in 100. So you can understand 1 in every 100 children born will be a Down syndrome child, and you don't want to bring in an abnormal child into the society. So for the health of that child, the ideal age would be anywhere between 24 to 40, but ideally it should be when you are at your healthiest best. And there is no rule. Suppose you feel that your career demands that you cannot get an earlier child, although you are already married, but your careers are challenging that you can't plan on a pregnancy right now, but you're worried that your ovaries will age. And so what to do? So what you can do is there are other options where you could, get your eggs retrieved and kept them frozen. So there is a process of egg banking or egg freezing where you are younger, your eggs are healthier at the age of 31, 32 or 33. If you're married or if you're unmarried, it's not necessary that only married girls can freeze their eggs. So there is egg banking and egg freezing facility which is available very much in India, where women can freeze their eggs and keep them time bound and keep them young at, as they were at the age of 31, and then get married and then have a pregnancy with their same eggs which are 7 years younger by biological clock.
Yeah, so you related to the whole concept of egg freezing, what you were just explaining and stuff. I feel like, that's really pertaining actually to the whole topic that we're looking at, especially because a lot of the people who are going to be watching this are females who are doing their MBA and who are building their careers right now. So I personally have not really heard about this as an option spoken much in India. I think I've just heard it like spoken of like in tabloids abroad and stuff. So it's really nice to actually like hear this as an option for people, because this is something that females have to choose between career and family planning at this age with their mid-20s and like entering into their 30s. So I think that was good to get some information related to that and know that it is happening in India.
Yeah, it is very much happening and it is very much easily available. The number of centers for egg banking and egg freezing are also majority of the metro cities are having them, but I think some of the smaller grade 2 cities are also now starting up with most some of the advanced IVF centers are having facilities of egg banking and egg freezing. And even if it is not there in your city where you are, of course we have centers in Mumbai for sure. But if anybody who's listening to us and who doesn't have an egg banking center at their city, they can always approach any of the metro cities and get the procedure done, which will not take more than 15-20 days, and they can fly back to their city. So it's as easy as that.
Okay, so it's not really evasive. It's pretty simple.
It's pretty simple. Like it's basically involves a few hormonal injections or tablets or medications to stimulate ovulation, and then eggs are retrieved through ultrasound. So it's basically those who've undergone in vitro fertilization or IVFs or who've undergone the procedure would know that it is not as difficult as an IVF, and it is basically an ultrasound done procedure. So they really don't have to undergo like a major surgery to actually get their eggs frozen or egg banked. Unless and until there are some who have to undergo egg banking, egg freezing, not for career, but for health issues. For example, there are some girls who are getting detected with breast cancers at very young ages, or getting affected by lymphoma or leukemias at young ages, at the age of 20 or, even in their adolescence. So in those cases, if they require to undergo chemotherapy or radiotherapy, then that is definitely going to affect their ovarian function. So even these girls can undergo egg banking or egg freezing or ovarian tissue preservation, which may sometimes have, if they have to undergo surgery for some cancer, then at that surgery itself, the ovaries can be retrieved or implanted at a different place and kept frozen, so that once they are out of the disease and they're in the recovery phase, they could still have their own child because their eggs were frozen and kept separately. And whatever chemotherapy they underwent, that did not affect their ovarian function.
Great.
Okay, like ma'am, I had a question. Like I got married around 7 months ago.
Okay.
So currently I'm 27. My wife is 25.
Yes.
So my parents are like, कि, like jaldi jaldi bachche kar lo. So it's like after 30 is having kids a problem? Like, do we face any problems?
Not at all. So after 30, like I said, after 40, definitely it's a problem. But after 30, not really. And there are certain tests which you or your wife could undergo, which will tell you what is your biological clock, basically how much egg reserve she has, which are simple blood
Okay.
tests, which can be done. You don't have to undergo some kind of a procedure or an ultrasound. So she could just get an egg reserve testing done by blood test and come to know whether she has good egg reserve or no. So if somebody who's not having any pathological problem in the uterus or in the ovaries, and her egg reserve is also good, then you really don't have to hurry for a pregnancy. But the egg reserve should be checked. So you should not go blindly. Meaning, what I'm trying to say is that age is not just the only criteria. The criteria is what is your biochemical age. So somebody who is 28 could still have a very poor ovarian reserve or an egg reserve, and at the same time somebody who's 35 may have a very good ovarian reserve. So it is individual. It is not like who is 27, who's 28. So just like a girl who wants to get pregnant at the age of 35 and she's got married only about a year back can have very good chances at pregnancy, whereas a girl who's married at 28 but her egg reserve is poor can have very poor chances of natural pregnancy. So that's why whatever you decide when you want to wait for planning, you require to undergo a preconceptional counseling. So that preconceptional counseling would include and help you decide whether you should plan pregnancy in the near future or whether you have enough time and you can plan 4-5 years down the line.
Ma'am, what you told the name of the test?
It's called serum AMH for the woman and a semen
Okay.
analysis for the male. So it's not only the
Okay.
woman, right? So it's the male and female both, to make a complete. So a semen analysis for the male will tell whether the male sperm count and everything is okay, because that is something also that deteriorates with age and with lifestyle. And in the female, it is called as anti-Mullerian hormone or AMH. So it's a blood test which can be done at any time of the menstrual cycle, and there are ranges. So based on that ranges, we will know whether her egg reserve is good or it is poor, and accordingly decide as to when you should plan a pregnancy.
Yeah, so actually, coming back to the point you just made, that age is not the only criteria we're taking into account planning pregnancy. So actually, I was recently having a conversation with one of my cousin's sisters. So she already has like 3 kids. So she was just relating. She was having certain health issues. So the doctor that she went with had suggested that she get a thalassemia test done because she's East Indian. So
East Indian. Okay.
East Indian, yeah. So she mentioned that the doctor had said that it's in that particular community, thalassemia is actually quite frequent, and actually it should be done before you have a pregnancy itself. Like you mentioned earlier, it's an important test to have to know whether you're a minor or major.
Right.
So yeah, so I just wanted to know, are there any other communities who are like at risk for this, or what exactly is thalassemia? How much of a risk is it when you're planning your pregnancy?
No. See, thalassemia is it's a hemoglobin abnormality where the globin chain that forms hemoglobin. So, hemoglobin comes from the word heme and globin. So heme is the iron and globin is the protein. Okay, so now this globin protein has got 2 forms. There are 2 different genes which control this globin protein. One is the alpha gene and one is the beta gene. And the alpha gene also, because since we have 2 pairs of chromosomes for everything, like we have 23 pairs of chromosomes which make 46 genes. So there are 2 alpha genes and there are 2 beta genes. So whenever there is a change in one of the protein content of that globin pattern, there are different types of hemoglobins. For example, so that is why there is something called as an adult hemoglobin. The hemoglobin pattern in a child would be different, which is called as fetal hemoglobin or hemoglobin F. And then there is something known as hemoglobin A2, which is a different form of adult hemoglobin or an alpha globin. Now, if you see a hemoglobin electrophoresis report, there are proportions of all these different types of hemoglobin in an adult body and in a child's body. So in a child's body, the hemoglobin F content would be much higher. Whereas as the child matures, the hemoglobin A pattern gets higher and the F goes down, and A2 is supposed to be less. So if the A2 or the hemoglobin A2 content is more than 3.5% of the total type of hemoglobin, then you may be having a hemoglobin abnormality. And then when you do a hemoglobin electrophoresis testing to know exactly which band of globin I'm having, that's when we come to know whether it is alpha thalassemia, whether it is beta thalassemia, or whether there is some other form of hemoglobin which is called a sickle cell hemoglobin. The sickle cell hemoglobin is a defect where the globin chain is such that it is very brittle. So the hemoglobin which is present in those kind of red blood cells, they are very fragile. So when there is a slight change in pressure situations or the flow of blood and all that, these red blood cells, they lyse or they break. So that is called as sickling. So what happens in hemoglobin electrophoresis when we do thalassemia or sickle, like I said, because there are two genes, if I am a carrier of only one gene, I do not manifest the disease. I am only a carrier. I have that gene in me, but I am not affected. So I am not going to have requirement of repeated blood transfusions, or I'm not going to have excess bleeding during my periods or excess bleeding from gums or destruction of my platelets. But if I am somebody who is having thalassemia major, that means my both genes are affected, either both alpha or both beta, they are affected. So I am somebody who from childhood will be always on a lower hemoglobin side, because my hemoglobin cells, my blood cells get ruptured very fast, they break very fast. I am someone who will keep requiring repeated blood transfusions, and sometimes someone will be very weak, okay, and will keep on getting recurrent infections, and lifelong I may require blood transfusions to bring up my blood, because the iron tablets are not going to build up my hemoglobin. That's not the problem. The problem is not in the heme, the problem is in the globin, right? You understand? So what was told to your cousin is there are certain, it's not exactly certain communities, but out of the testing that has been done in hemoglobin electrophoresis or through the blood samples of different communities, it has been found that in the northeastern population and in the Jewish population, the chances of this hemoglobin thalassemias and sickle cell anemias, even in Sindhis, are found to be on the higher side. And most of the time, since we have marriages in the same caste, not up till recently, but recently things are changing in the last 10 years. But till then, there were usually marriages in the same caste. So therefore, whatever these genetic abnormalities, they were always passed on in the same community or in the same caste. So that is the reason why, since they said that in the northeastern population, the incidence is higher. Usually, if you know that the Parsis, they usually do not get married into other communities. So in the Parsi community, the chances of this hemoglobin pattern continuing in the same community is higher. Sindhis similarly, but since we have a large variation in intercaste marriages now happening, and also because there are a lot of love marriages happening, so there will be girls who will come to me who may be a Maharashtrian, but her father may be a Sindhi and her mother may be a South Indian. So we really cannot judge only by the caste that whether you will have this hemoglobin abnormality or no. So every time a woman comes in pregnancy for the first time, if she comes before pregnancy, like I told you, if they come for a premarital counseling, ideally that is the time that their hemoglobin pattern should be checked. And that is the reason why, because we don't want them to then have a sibling or a child which will have a major defect in the thalassemia or the sickle cell. A carrier state would be fine, but a major defect would cause them to have a child who will require repeated transfusions, will keep falling sick all the time, that way. So ideal time would be premaritally, but if it's not happened premaritally, then every girl or every woman, at least in the metro cities, who comes to for a pregnancy checkup, in the first 3 months itself, the gynecologist gets a hemoglobin electrophoresis done to know whether this lady is a thalassemic minor or a sickle cell carrier, or any of abnormal hemoglobin carrier. And if the woman is a carrier, then we check the partner as well, because then we want to know whether there is a possibility that both are carriers and the child may be affected.
Okay, now it's much more clear now that you explained it that way.
Yeah.
Yeah. So I think coming to the last question I have is probably just related to the actual process of birth. So a planned birth. are there any risks associated to having a C-section versus a natural birth, or taking certain drugs for the pain during a natural birth? Are there any risks related to that? What are the pros and cons of either? I know it depends on a lot of other things about the, the actual conditions of the birth too, but if you're like, say, planning ahead, some people, I think opt for a C-section sometimes. So,
right. See,
yeah.
All said and done, a normal vaginal delivery is called a normal vaginal delivery because it's not a surgery and it is a natural normal process. So whenever or whatever is a natural normal process is always going to be safer compared to any artificially induced process. Obviously, for obvious reasons, is because when your body undergoes a normal labor process, the labor, the triggers and the labor pains are natural, so you are not synthetically giving any doses or giving any injections, so you don't have to control the dosage of the trigger that you have to give, or worry about the side effects of the trigger that you're going to give, or worry about it's going to be too much or it's going to be too less, because it's natural, right? But when you have to induce labor, there are a lot of other things that have to be kept in mind, that although the drugs that we give to prime the cervix or to induce labor are synthetically made drugs of the same hormone, but they are nevertheless synthetically made. So every woman's body may respond differently to that drug at the same dose. So if I give a certain dose of the synthetic oxytocin to 10 ladies, each of them may have different responses to it, meaning some may get pain, some may get mild pain, some may get very severe pains with that same dose. You understand? So that is why whenever we give a synthetic drug and induce labor, it's going to be more risky, because we don't know what will be the response or the impact, or what will be the response of that particular case or woman. And that is why whenever there is induced labor, that lady has to be strictly monitored. Unlike when a natural or a normal delivery process happens, the woman can be home at for 2-3 hours or 4-5 hours, till her pains become really strong and she reaches the hospital, so that her hospital time is saved. But if it is a synthetic process and we have to induce labor, we can't give those drugs at home, because the woman and her baby's heartbeat and the progress and her blood pressure and other vital parameters have to be monitored. And we have to be prepared that there can be something going wrong, and we have to catch it at the right time before it causes any harm to the mother or to the baby. Now, when you talk about a C-section and a normal delivery, a C-section, having said, the baseline is that a lower segment cesarean section is a surgery. So obviously it is going to be more difficult and more invasive than a normal delivery. Let me put it that way. Because there is going to be a surgery. But there are more and more conditions coming up where women are becoming less favorable for a normal delivery, and there could be multiple reasons for it. For example, the average baby weight has increased compared to the baby weights that used to be there in 20 years back. Earlier, like I said, undernutrition and malnutrition was a problem. Now overnutrition is a problem. So our babies are now majority of the times being more than 3.5 kgs. The newborn babies, rather than the initial average, which was used to be 2.5 plus. So the weight of the babies are changed. The physiology or the physical activity of our mothers has changed. Earlier, we used to have a more sitting down position. Eating food was always in a squatting position, or people used to most of the time sit down rather than actually sitting on chairs and sofas. Now you will barely find any pregnant lady actually sitting down on the floor and eating, or mopping the floor or doing squatting exercises, very rarely. Because we have maids in our house. So, the maid does all the squatting part, and then we do not actually physically exercise as much. Most of the times pregnancies, we actually wait till the 8th or 9th month before we can actually start doing some walking also in pregnancy. So because of all these factors, unfortunately, the favorability or the position of the baby, natural labor starting on their own have reduced. The trigger factors which the women get generated on their own to go into labor have reduced. And that is why there is a more chances of elective C-sections happening, number one. Secondly, women also don't want to bear the pain because they're very scared that, I don't know whether I'll be able to handle labor pains. And they're like, if anyways I'm going to end up with a C-section, then why don't I just electively plan for a C-section? So that is also a theory which has come in people's minds. Yes, C-sections have become safer than what they were 20 years back, because now more techniques of sterilization are being used, more hygiene is being followed, better antibiotics and medications are available, which can even control infections before they occur, even before they occur. And therefore, the complications of cesarean sections have gone down. But having said that, nevertheless, normal delivery is still called normal because it is a vaginal natural process, and a cesarean section isn't a surgery. But both these methods have now, because of the standard of care that we've been able to achieve in India overall, both of them have become safe, almost literally neck on neck for our mothers.
So then I think the only question that I probably have left is about the spacing of births. So I was reading up somewhere that generally, like between having children, you should have like a 1 to 2 year gap for the female body to recover. So what are some of the changes that happen actually in the female body after pregnancy that the female actually needs to recover from, not just physically, but also mentally?
Okay, see, physically, first of all, that there are a lot of changes that happen in a woman throughout her one single pregnancy. For example, so some may go less noticed, some may be very visible, but physiologically, there are a lot of changes that a woman undergoes during pregnancy. Most of our Indian women are anemic. They are less in hemoglobin, and this anemia gets revealed out especially at the time of pregnancy, because that is the only time when they actually undergo blood tests and we come to know what are their hemoglobin levels. And pregnancy, unfortunately, is the only time where women take supplements. How many times do you know girls who take supplements? Very rarely. So unless and until you actually get into pregnancy or get into a situation where you are actually nursing, you don't take supplements. So that's why you've been taking supplements only for a period of 9 months or probably 3 months after delivery to actually get back your lost iron stores. Now, while a woman is breastfeeding and even while she's pregnant, all the nutrition, iron, calcium that is there in her body goes to the womb, through the womb or through the placenta to the baby. And even after delivery, at the time of delivery, each woman loses about 500 to 600 ml of blood. Overall blood volume is 5 liters, out of which on an average, I'm talking about the minimum blood loss, is at least 500 to 600 ml, which the lady would take minimum 2 to 3 months to get back or bring back or cope it up. Second is that she's still, while she's breastfeeding, she loses a lot of her iron, calcium, proteins are going to the baby through her breast milk, right? And the best time to actually continue breastfeeding is ideally to continue lactation is nearly 1.5 to 2 years, because all the antibodies from the mother, what she has achieved through her life, through different infections or through vaccinations, will all go to the baby through her breast milk. So she's breastfeeding. So while she's breastfeeding, she's still on a deficit of iron and calcium, because although she's taking supplements, they're all going to the baby as well. So she's still on a lesser balance. So if you plan on a pregnancy before 1 year, then the woman has actually not got back all her vitamins at all. So she's already getting into another pregnancy while she's deficient with hormones, vitamins, sorry. And so, there is a lot of complications then arise. For example, extreme or severe backache issues, then hemoglobin being very low, and, severe anemia. Severe anemia can cause complications like hypertension in pregnancy. Severe anemia can cause repeated infections in pregnancy. If the woman has undergone a C-section, then having a C-section, again, within a matter of 2 years, has a very high incidence of cesarean scar dehiscence or scar of that C-section rupturing, which will cause obviously death of the baby or life-threatening situation to the mother as well. So that is the reason why the ideal birth spacing would be 2 years. So ideal birth spacing would be at least 2 years gap between two pregnancies, whether they are normal or C-section. It is not that if you've had a normal delivery, because you've had a normal delivery, you can plan on a pregnancy again after 6 months. No, the woman is still breastfeeding. So the woman is definitely deficient in her vitamins. Second thing, you talk about the mental aspect. So whether she underwent a natural delivery or a C-section, mind you, normal delivery, I don't want to scare anyone, but normal delivery, a woman experiencing normal labor has experienced the worst pains in her life. Apart from the kidney stone pain, this is the worst pain in her life, and it leaves a mental impact on the lady. All said and done, it affects her mental health. There is a certain amount of trauma that always remains in her mind, and that scared or fear that I have to undergo that pain again. So unless and until she matures as a mother, she doesn't get the strength to overcome that fear, okay, and to go through that ordeal all over again. So that is why, and in addition to that, not even able to sleep, she's having sleepless nights because every 2 to 3 hours the woman has to get up and breastfeed her baby. And then, so for a period till her actual child becomes 1.5 to 2 years, there's really no sleeping pattern that the mother can follow. So the ideal space of 2 years is to complete all these, so that the woman gets back into her natural physical health. 2 to 3 months after delivery, she's not exercised, she can get back to exercise and get back into fitness. In that time, she can lose weight if she's put on too much weight in pregnancy, in her first pregnancy. Second, she can get back her vitamins. Third, she can complete lactation and breastfeed her child fully for 1.5 to 2 years, so that breastfeeding has a multiple advantages for the baby. And I don't want to highlight that because that would be like a never ending session. But in short, ideal period that is breastfeeding is an elixir for life for the baby. So she can complete and give full justice to the breastfeeding for the first child, rather than compromising on it and cutting short because she's got pregnant the second time. And the fourth is that now the baby is also independent enough after 1.5 to 2 years that she can now give attention to a second newborn. So the first child is also neither too over possessive, at the same time the child is also not neglected. So looking at all these parameters, 2 to 3 years, meaning minimum should be 2 years, it can be extended beyond.
Okay.
Yeah.
All right. Great. Yeah, so I think we have covered pretty much everything we wanted to discuss, and we have covered like quite a few topics I feel related to family planning, and even earlier with PCOS and PCOD. So yeah, I think that's we can probably conclude over here. I would just like to thank Dr. Veena for speaking with us today. This has been a really enlightening conversation. I hope that by having a male perspective also, who's probably not really, who was a novice on this topic, which I think most females would be at some point, it's probably helped us like understand it a lot better.
Yes, I think it's good that you've had some male participants, and our chief interrogator is also a male, so that's good.
Yeah.
Because it does show that we are all on the same page, and girls don't have to feel shy about discussing about their PCOD, and it's not just a female's problem. It's a problem that's going to affect society in general, and I think we should be quite open about it.
Yeah, exactly. And I'm really glad we got to discuss that today. I felt like that really came.
So I would like to, I can't really express the whole feeling about the conversation because I'm the person who believes in perspectives and, thinking from the other side as well. So every podcast I record, I get this other perspective and a whole new dimension of information, which reflects really well, and it was really, I'm really honored to have you on the podcast and really loved having this conversation, and thank you everyone to be there.